Hi, everyone. My name is Lisa Galea, and I'm one of the organizers of this conference. And this is our last event. Yay! Actually, I think we have one more social event, but this is our last academic event, I guess I should say. And it's our Hot Topics Symposium. And I'm really, really excited to hear all of these amazing talks. They are super hot topics. I was going to say something else too, but they are amazing people all in their own right. So I'm very excited. But before we start, I just wanted to give a land acknowledgement. I know not all of you are in Canada, but those of us that are in Canada, I want to say that we recognize that we live, work, play, and participate in the community on the unceded, ceded, and traditional territories of the 203 First Nations, along with the 38 Métis chartered communities, each of which possess their own unique traditions and history here on this land that we now refer to as British Columbia. That's where I am right now. And we acknowledge the importance of the Truth and Reconciliation Commission of Canada's call to action, the United Nations Declaration on the Rights of Indigenous Peoples, and the BC Declaration on the Rights of Indigenous Peoples Act. In all of our work at the cluster, we're committed to ensuring Indigenous women's rights to health and safety and equal opportunity to participate in a manner that recognizes and respects Indigenous cultures and traditions. And today I'm joining you from North Vancouver, that's where I am right now, which is part of the unceded homelands of the Coast Salish peoples and the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. And for all of you joining from wherever you are, I urge you to please look up the Indigenous peoples within your regions. So this is part of the Women's Health Research Cluster, and we have over 260 members, faculty, students, community partners, trainees, media. We have a lot of people in us. I think we have now 13 countries, 13 or more countries represented, which is amazing. We have trainee research presentation series. There's a quarterly, so I urge you, if you're a trainee, to consider joining up for that. And we have a women's health seminar series. We're really close to announcing our lineup for next year. That's all free events and a number of other events that we have. We also have a number of trainee awards that we give out, and just hint, we have very good success rates, like very good, not like NIH level or CIHR success rates that are in the very low double digits. It's much higher double digits, maybe even triple. So please encourage your trainees to join and to apply for them when they come up. And the cluster is all about connecting people, listening to different perspectives on things that are important for women's health, as well as sex, gender-based analysis, or our LGBT community as well. So we couldn't do this without the support from our sponsors. We have a number of them, which are listed there, including CIHR, which is Canadian Institute of Health Research, and the Michael Smith Foundation for Health Research. So without further ado, I would like to stop sharing my screen, which I'm sure you are very happy with me stopping sharing my screen, and introduce my dear friend. All of you are my dear friends, my dear friends. The first of which is Dr. Karen Frick. And while she's setting up her talk, I will give you her bio and her fun fact. Dr. Frick is a behavioral neuroscientist and neuroendocrinologist. She's a distinguished professor of psychology at the University of Wisconsin-Milwaukee, an adjunct professor of pharmacology and experimental therapeutics at the Medical College of Wisconsin, and the chief scientific officer of Estrogenics Therapeutics, Inc. She's the editor of the book Estrogens and Memory, Basic Research and Clinical Implications, that was published by Oxford University Press in 2020. It's a great book. There are some chapters featured by people on this call, and she has nearly 30 years of experience. Doesn't that sound like, we're ancient? But I assure you she's not ancient, but she has nearly 30 years of experience studying neurobiological mechanisms that underlying memory formation, with a particular focus on cellular molecular mechanisms through which estrogens regulate memory consolidation. And she gave us a number of fun facts to choose from, but I'm going to give you one, which is that she rode greater than 150 miles. And for those Canadians, everybody else, except for the Americans among you in the audience, that's greater than 2,400 kilometers. And on her road bike in 2020, that is amazing, Karen. You must be in fantastic shape. So,
well, it was in 2020.
Yes. Yeah. Well, it is 2021. You're right. Thank you again, Karen.
Thank you. Thank you so much, Lisa. And I want to congratulate Lisa and Catherine and everyone at the Women's Health Research Cluster for putting this just absolutely fantastic series together this year. Thank them for this really a public service for bringing together people who are interested in women's health issues. So thank you very much for doing that. And today I'm going to talk about some of our work trying to take our basic research in mice and translate it into potential therapies for menopausal women. And I'm going to focus on our work with estrogen receptors, which you can see from this this figure are distributed in tissues throughout the body. Today we're going to be particularly we'll talk about the ones that are in the central nervous system, particularly the ones that are in the hippocampus. So if I can get my screen to advance, there we go. So the central question in my lab is how does estradiol regulate memory? So what are the cellular molecular mechanisms through which estrogens like 17-beta estradiol act on brain regions like the hippocampus, as you see here in these, sorry, these orange and yellow colors to make a memory. And we focus on the hippocampus, which you see here in the rodent brain, because it's important for many of the kinds of learning and memory that are deteriorated in aging, in Alzheimer's disease, spatial memories, contextual memories, memories for objects and their locations. And there are lots of estrogen receptors in the hippocampus. So the traditional intracellular receptors, ER alpha and ER beta, are located throughout the dorsal to ventral extent of the hippocampus, as is a third membrane estrogen receptor, GPER, which I won't be talking about today. There are a lot of ways in which we can test memory in mice. The ways that we've been focusing on in the last decade or so are these very simple object tasks where we place common household objects into an empty white box. And after the animals have habituated to them, we simply allow them to spend time exploring them. And we keep them in the box until they've explored the objects for 30 seconds. And once they've done that, usually most of our treatments are acute treatments done immediately after training so that we can pinpoint effects specifically to memory consolidation. And that will be the case for much of the data I'll show today, but I'll also talk about some studies where we've done more chronic treatments that are given pre-training. But in any case, the important thing is that when we're testing the animal's ability to remember what the objects are, that's what we call object recognition. And in that case, testing allows the animals to explore an object that's identical to one they've seen before in training and a new object. And because mice are inherently drawn to novelty, they like new things. If they remember the familiar training objects, they'll spend more time than chance, which in this case is 15 seconds, exploring the novel object, this little pink stapler here. We can also look at the animal's spatial memory in this task by doing a similar kind of training with two identical objects, again, usually a post-training treatment. But then instead of introducing a new object, we simply take one of the familiar objects and move it to a new location in the box. So here, the lower corner, and we call that task object placement. And so again, the key is what's going on during testing, new object, or just a moved object. And this is an example of the kind of data that we see in this task. So 30 seconds, again, is the maximum amount of time they can spend with either object, and 15 seconds chance. And you can see that vehicle-infused animals are spending the same amount of time, chance amounts of time with the two objects, meaning that they don't remember the familiar training object. They don't spend more time with it than the training object. But animals treated with estradiol in a number of different ways. In this case, this was a dorsal hippocampal infusion. These animals spend significantly more time than chance and then the vehicle-treated animals with the novel object, telling us that they remember the identity of the familiar training objects. And we see the same thing for object placement. Animals treated with estradiol spend more time with a moved object than the unmoved object. And we've seen this pattern of data so often in the last couple of, last decade really, that we use these tasks as behavioral probes to try to understand what's happening in the brain that causes this memory enhancement. And this is a model of where we are at this point. Now, I'm not going to go through in any exhaustive detail here, but just to point out these are the important receptors in purple and blue, kinases in green, and genetic and epigenetic factors in orange that we know are important for estradiol to do things like regulate protein synthesis and dendritic spine density in the hippocampus, as well as the prefrontal cortex, and enhance memory. And I'll just focus on the middle here. We started off by looking at the phosphorylation of this kinase called ERK, or extracellular signal regulated kinase, which needs to be phosphorylated for animals to form long-term memories, irrespective of estradiol. But in fact, we found back in 2008 with young animals, and these data are from a 2010 follow-up with middle-aged animals, that if we treated animals with estradiol, we either infused it into the dorsal hippocampus or into the dorsal third ventricle, that within 5 minutes, we saw a significant increase in the P42 isoform specifically of ERK, that isoform was phosphorylated as a result of estradiol treatment. And a compound called UO126, which is an ERK phosphorylation inhibitor, prevents estradiol from increasing ERK's phosphorylation, as you can see here. But interestingly, that inhibitor also prevents estradiol from enhancing memory. So here you can see again, estradiol infused alone enhances memory, in this case in the novel object recognition task, and then UO126 blocks that effect. So back in 2012 or so, maybe a little earlier, a former postdoc, Marissa Boulware, came to my lab from Paul Mermelstein's lab, where as a graduate student, she had shown that ER alpha and ER beta, which are, have been historically known for their effects in the nucleus, that these two receptors could interact with metabotropic glutamate receptors, particularly mGluR1A, to increase Krebs phosphorylation. And ERK also leads to Krebs phosphorylation. So Marissa wanted to know whether ER alpha and ER beta agonists could enhance memory, and if they did so by activating ERK phosphorylation. So she did a study where she infused into the dorsal hippocampus the ER alpha agonist PPT or the ER beta agonist DPN, either alone or in combination with the ERK phosphorylation inhibitor UO126. And she found that when she infused PPT and DPN on their own, we saw, again, a significant enhancement of object recognition and object placement that was very similar to what we've seen with estradiol. So activating either agonist can enhance memory, but she found that UO126 blocked that effect. So clearly that memory enhancement was dependent on ERK phosphorylation, just like with estradiol. And you can see the effects on ERK phosphorylation down here. These are PPT and DPN on their own, and PPT and DPN with UO126. So these data suggested that ERK activation was very important for ER alpha and ER beta to enhance memory in females. What about that interaction with that metabotropic glutamate receptor? Here she infused PPT and DPN on their own, or in combination with an mGluR1A antagonist, LY367385, and found again, PPT and DPN on their own enhance memory, but not in combination with this mGluR1A antagonist. And this antagonist also prevented PPT and DPN from increasing ERK phosphorylation, telling us that ER alpha and ER beta are interacting with mGluR1A at the membrane. And I forgot to mention that Marissa also did some co-IP experiments showing that there is a physical interaction among those three receptors at the membrane. And that interaction triggers ERK phosphorylation and memory enhancement. So what's the potential clinical significance of a basic research finding like this? Well, this sex difference really drives our research. So this is data, these are data showing the estimated lifetime risks of developing Alzheimer's disease at ages 65, 75, and 85. And you can see men in the purple and women in the gold, and women are at greater risk of developing Alzheimer's than men at any age. And so we think this is due at least in part to hormone losses in menopause, which, as you can see, pre-menopause estrogen and progesterone levels are obviously, they're high in cycling women. And then in perimenopausal women, we see a decline in estrogen and progesterone levels that then remains low in the 50s and beyond. And this is important for hippocampal neurons because they come to depend on estrogens as trophic factors. They need estrogens to function properly. And so we think that during menopause, when you have this massive loss of estrogens, that makes these neurons more vulnerable to cellular changes in aging and neurodegenerative diseases like Alzheimer's. Estrogen replacement can help with that. However, while there are some benefits of traditional premarin-based hormone therapies like strengthening bones and improving cholesterol profile, and importantly, many forms of estradiol or estrogens will reduce menopausal symptoms like hot flashes, there are some detrimental side effects, small risks, but they are there for breast cancer, uterine cancer, and heart disease. Those cancer risks are due in large part to ER alpha. So ER alpha increases cell proliferation and tumor growth, whereas ER beta does not, in fact, decreases cell proliferation. So because both receptors enhance memory for the purposes of memory enhancement, or treatments that may help reduce incidence of dementia, we think that ER beta, it would be the obvious logical choice between those two receptors. So if we could target ER beta, maybe we could get some of the benefits of estrogens without some of those side effects. But there are some problems in that ER beta agonists aren't all that selective. So DPN, which I showed you earlier, enhanced memory is only 70-fold more selective for ER beta over ER alpha. Other ER beta agonists are less than 70-fold more selective. So all these compounds can still bind ER alpha at higher doses. And we wondered whether we could develop a more selective ER beta agonist to safely treat memory loss. And so we started doing that in collaboration with Bill Donaldson, who's a chemist at Marquette University here in Milwaukee, and Dan Sem at Concordia University of Wisconsin, who's a biochemist and pharmacologist. And Bill's lab has synthesized probably 100 of these compounds that are selective for ER beta. You see our lead compound here, we call EGX358. That structure is in red, superimposed on the structure of 17-beta estradiol. And this compound binds ER beta with very high potency and extremely high selectivity. So you can see it's 750-fold more selective for beta than for alpha, which, compared to DPN and other compounds is quite a bit higher. We've also done some work showing that it doesn't bind to other nuclear hormone receptors. It has no effects on metabolic profile, no increases in breast cancer cell proliferation, and no effects on sort of gross tissue pathology. And so a few years ago, a former grad student of mine, Jae-Kyun Kim, did a series of experiments with young overrectomized female mice administering EGX in one of 3 different routes of administration. He first started with dorsal hippocampal infusions. These are bilateral infusions. Again, vehicle, DPN is positive control, and then multiple doses of EGX, and found multiple doses enhanced memory. This is true of both tasks. I'm just showing you the effects on one because they're identical for both. He also gave it via IP injection. And again, I should mention, these are acute treatments. These are given immediately post-training because that's my lab's MO. That's what we usually are doing. So our initial study, we went with what we knew when we did acute treatments. So here, IP injection also enhances memory, as does an acute oral gavage, multiple doses, enhanced memory in both of these tasks. So we published these data in 2018. And also in 2018, we founded Estrogenics Therapeutics, a company to try to develop these compounds. I'm functioning as the chief scientific officer of the company. And around this time, we participated in an NSF I-Corps program to try to better kind of refine the goals of the company. And part of that program, you talk to a lot of people, particularly people who might use your product. And so we talked to a lot of menopausal women and their physicians, as well as people in pharma. And we found that physicians and patients weren't thinking about Alzheimer's disease. That was way too far down the line for them. So it wasn't really on their radar, but they were concerned with some memory loss they were having or difficulties with attention and concentration, during the perimenopausal period. But they were also really concerned with hot flashes, anxiety, and depression. And so we started retooling in the lab to figure out how we could measure hot flashes in mice, and pulling in some common anxiety and depression measurements. And this work was done by current grad student Aaron Fleischer. And so Aaron started a study that we published earlier this year, where we then gave long-term oral EGX358. So as I'll show you in the next slide, He gave this compound to animals for about 2 months via oral gavage. Each day they were given that something was happening, testing. They were given it an hour before testing. We started measuring hot flashes using tail skin temperature as a proxy for body temperature. So mice can't sweat like we do to release heat, and they can't pant like dogs do to release heat. They release heat out their tails. And so we can use infrared imaging to measure tail skin temperature. And here you can see images of an animal that was injected with vehicle with a nice cool tail versus animals that were injected with a neurokinin 3 receptor agonist called Senctide, which increases core body temperature and tail skin temperature. And you can see quite the difference there. So we measured animals in this study were dosed daily with vehicle, estradiol, DPN, or EGX, and then we ran them through a battery of tests. The tail skin temperature for anxiety-like behaviors, open field and elevated plus maze, for depression-like behaviors, tail suspension and forced swim test, and then for memory, object placement, and object recognition. We also mentioned body weight because we were weighing the animals for dosing every day. So I'll show you a little bit of those data. And this is the timeline of the experiment. The animals are overactimized, allowed to recover. They were treated with the compounds for 2 weeks before we started doing anything to them. Then we did the temperature measurements. We did the anxiety depression test, but I won't show you any of those data because we didn't really see anything interesting there. Memory testing, and then I'll show you some body weight data. So this is the structure of Senctide, again, a neurokinin 3 receptor agonist. When we injected animals with vehicle, we saw a slight uptick in temperature as a result of the injection, but that went away, went back to baseline pretty quickly. No treatment-induced changes here. When we treat the animals with Senctide, you see a very rapid and, for animals, pretty substantial. I mean, this is a difference of 3 to 4 degrees of temperature, rise in temperature that was pretty transient. And you can see that all 3 of the estrogen compounds reduce the magnitude of that hot flash. So we're really very encouraged by this. In terms of memory, we see all 3 compounds improve memory in both tasks. No effect on anxiety, depression-like behaviors. In terms of body weight, you see, animals gain weight after overectomy. We expected that, and then they gain weight a little bit over the course of the study, but there's no treatment effects here. So conclusions from the EGX358 studies, it's a new ER beta agonist that's 750-fold more selective for beta than alpha, has no negative effects that we've found so far. It enhances multiple forms of hippocampus-dependent memory via multiple routes of administration, including oral, which is great. And we found that long-term treatment enhances memory, reduces drug-induced hot flashes, and has no adverse effects that we've been able to detect so far. Next steps are we're currently testing the animals, or we will be testing them this summer, testing a mouse model of Alzheimer's disease with EGX358, and we've got a grant in to hopefully be funded to look at aging animals. So for general conclusions, our basic research tells us that ER alpha and ER beta enhance memory in overactimized females by interacting with mGluR1A and rapidly activating cell signaling. Based on data from others, we suspect that ER beta is the superior target to provide both memory formation without with some tumor suppressing effects, without side effects. And EGX358 is a novel, potent, and highly selective ER beta agonist that enhances memory and alleviates hot flashes in this OVX model of menopause, and could be a promising treatment for reducing hot flashes and memory dysfunction in early menopausal women, with maybe even some possible long-term benefits on dementia further down the line. So I'll end there by acknowledging Marissa, Jay Kuhn, and Aaron for their work, our funding agencies, and thank you for your attention.
Okay, thank you, Karen. Yes, please do your little emojis if you can. So Kristen has a great question. My question is kind of similar, not really, but I think you can piggyback both of them. I can read out Kristen's question unless Kristen wants to unmute.
Okay, hi, Kristen.
Unmute. Hi. And when you're listening to Kristen's question, can you also think about body weight? Because that was kind of an interesting finding, but go ahead.
Yep. Wonderful talk, Karen. I was wondering, so hot flashes in women have been linked to increased white matter damage. And so I'm wondering if your drug that you're giving to induce the hot flashes is causing white matter damage, and if your treatment is also reversing that, and that could be part of the mechanism.
Yeah, that's a really good question. That's definitely something we should look at in the future. We the animals in that study only received cyanide once.
Okay.
So yeah, I mean, I wouldn't expect any changes there, but obviously that's an important question, is the effect. Women obviously experience hot flashes, many hot flashes a day over long periods of time, and could a compound like this combat that kind of assault on the brain? So I don't know, but that's an excellent question that we should definitely look into.
Troy, oh, you're getting a lot of questions, so we won't get both of them, but Troy has a good one. Troy, did you want to, and you can ignore.
I can see Troy's question in the chat too.
Troy, but it's nice to listen to them. Troy, go.
All right. So I was just wondering about EGX and your administration in overactimized females. Have you done it for a long period of time, or is this only short time? Because there's always differences between a short exposure versus 6 months, blah, blah, blah.
Absolutely. Yeah. So far this 2 months of treatment, that's the longest we've gone.
Okay.
And we were lucky to get that, because the study was that study was concluding at the very end, the very beginning of the pandemic. So we were allowed to just kind of finish that, and the campus was shutting down, and we were allowed to just finish that up. But that's a really important question. So we haven't done 4 months or 6 months to see if there's any detrimental effects of really long-term treatment. I should also say that as part of, we've submitted a couple of grants to look at, to do more detailed pharmacokinetic work and metabolomics work, and so on. So hopefully we'll get funded to do that, so we can make sure that there isn't something detrimental about this compound that we haven't looked at yet.
Okay, I'll save my body weight, body fat question for after that, after you get that grant and do that metabolomics. Thank you very much, Dr. Frick. I'm going to now turn it over to Dr. Bean, and I'm going to read out her bio and her fun fact while she sets up for her talk. So we're sort of switching gears here now, and I think Dr. Bean will be talking about probably postpartum, peripartum mood. Yes, she is. Yay. So, Dr. Laura Bean is an assistant professor in the Department of Psychology and director of the neuroscience program at Haverford College. There, she works side by side with undergraduate students to conduct cutting-edge research, which absolutely, you're going to hear about that in just a second, in behavioral neuroendocrinology. And her current research focuses on hormonal changes during the peripartum period and how these cause changes in the brain that might contribute to the etiology of peripartum mood and affective disorders, one of my favorite topics. And her fun fact is that she has been done something I will not do, which is she's gone skydiving and bungee jumping, although she does put a little caveat there saying back when she was young and brave. So without further ado, take it away, Dr. B.
Thanks so much. Thank you very much for inviting me to speak today. I'm very excited to be here. So excited, I think, in fact, that as I was going over my slides last night, I realized I put a ton of data in here, and my slides are more like a data blitz. And so I apologize in advance for throwing a lot of data to you, but I will try to stick to the 15 minutes so that there's lots of time for questions if I'm not clear about anything. And so, like Lisa said, I'm at Haverford College. This is what it looks like. It's quite pretty. And it's a small liberal arts college just outside of Philadelphia, Pennsylvania. And it's quite tiny. So we have fewer than 1,400 students, and all of them are undergrads. So all of the work that I am going to show you today was driven primarily by undergraduate students in my lab. And I will try to highlight the students who did the work as I go. And so, I'm a behavioral neuroendocrinologist here at Haverford, and a recent focus of my lab is trying to understand the peripartum period. And we're interested in this peripartum period because we know it's a time for huge changes in behavior, right? So these can be positive behaviors like caregiving behaviors, behaviors associated with lactation, but we also know that there are some less positive aspects, for example, changes in mood and affect that may be correlated with peripartum mood and affective disorders, as well as changes in sleep. And then just like there are these changes in behavior, we also know that the peripartum period is a time of huge changes in hormones. So we know that in all placental animals, estrogen and progesterone levels rise dramatically during pregnancy. So estrogen in particular rises quite a bit by the 3rd trimester. It can be up to 100-fold higher than prepartum levels. But then following delivery, the placenta, most of this estrogen is coming from the placenta. So following delivery and the expulsion of the placenta, those estrogen levels drop, and they drop dramatically down to below prepartum levels. And then they stay suppressed until ovulation resumes, which depending on the species and on the individual, that can be weeks to months later. So put another way, peripartum women go from experiencing the highest amount of estrogen that they'll see in their reproductive life to the lowest amount of estrogen that they'll see in their reproductive life in a matter of days. And so we're interested in those changes. So we're trying to understand how those dramatic hormone fluctuations lead to changes in the brain, neuroplasticity, as well as whether those neuroplastic changes are correlated with changes in behavior. And so in order to do that, we have turned to rodent models. And the work that I'm going to tell you about today is focusing on a particular rodent model that was developed by Lisa and her lab group back in 2001, so 20 years ago. And it's called this hormone simulated pregnancy model. So in this model, you take female rodents and you ovaryectomize them to remove their endogenous source of ovarian hormones. And then you give them daily hormone injections that approximate estrogen levels and progesterone levels, although a little bit to a lesser extent, during pregnancy and the postpartum period. And so these doses were actually initially chosen for their ability to elicit maternal behavior in nulliparous female rats. And so there's some ecological validity there. But we also know that Lisa and then others after her have shown that following this sort of hormone simulated pregnancy, there are behavioral changes that may be indicative of depressed mood or heightened anxiety, as well as some profound changes in the brain. And so most of the work so far has focused on changes in the hippocampus. For example, Lisa's group has shown decreased cell proliferation in the hippocampus. And so just to give you an idea of what this model actually looks like, you can divide it roughly into early pregnancy, late pregnancy, and then the postpartum period. During early pregnancy, animals receive low estrogen and high progesterone. During late pregnancy, they get that high progesterone, kind of trying to mimic what we would see in the 3rd trimester. And then during the postpartum period, we can withdraw them from estrogen. So our estrogen withdrawn animals are mimicking that big drop in estrogen that we would see during the postpartum period. We can then compare those to animals who continue to receive estrogen during the postpartum period. So we call those estrogen sustained animals, or to control animals that are ovaryectomized and then receive just oil injections. And then more recently, we've been trying to include a comparison to just cycling females as well. And so today I'm going to try to tell you 3, if there's time, quick stories that are all using this hormone simulated pregnancy model to try to understand the role of these hormone fluctuations on the brain and on behavior. The first story that I'm going to tell you has to do with how estrogen withdrawal impacts anxiety behavior during the postpartum period in Syrian hamsters. And I'm going to blow through this one pretty quickly because it was actually just published recently, so which we're excited about, but also that means you can read the paper if you want to know the details. And so then I'm going to spend more time on these last 2 parts. So the second story is looking at how estrogen withdrawal impacts anxiety and some measures of motivated behaviors through delta phos-B levels in the nucleus accumbens in mice. And then the third is brand new data, just like weeks old data from my lab, looking at a new direction, which is how these peripartum estrogen fluctuations may impact sleep and some potential neural targets as well. Okay, so I'm going to start with the first story, which is the estrogen withdrawal and anxiety behavior in oxytocin neuroplasticity. And so the way that this works, so you'll see actually throughout the talk, I try to highlight the students who actually did the work. So that's these ladies down here. So the way that this works is that we had adult female Syrian hamsters who we ovaryectomized, and then we put them through the hormone simulated pregnancy injection regimen that I just told you about. We adapted it to a hamster gestational length because hamsters' gestation is actually a little shorter than rats. And so they were randomly assigned to one of 3 conditions, either this estrogen withdrawn condition that again mimics that postpartum drop in estrogen, sustained animals who continued to receive estrogen throughout the postpartum period, and then a no hormone condition. during the simulated postpartum period, they were tested for anxiety behavior. So similar to what Karen talked about, we used the open field and the elevated plus, as well as their sucrose preference, which can get at anhedonia, which is one of the core features of depression. At the conclusion of the experiment, the animals were perfused, and then we used immunohistochemistry to look for changes in oxytocin immunoreactivity in the paraventricular nucleus and the supraoptic nucleus, so the two primary sources of oxytocin in the brain. And so first, behaviorally, we found that these estrogen withdrawn animals showed a high anxiety behavioral phenotype. So in the elevated plus, you can see that our estrogen withdrawn animals are spending more time in the closed arms than the open arms. And likewise in the open field, they're spending more time in the periphery than they are in the center. And this is different from our sustained or our no hormone animals. In the brain, we can see that when we looked at our oxytocin immunoreactive cells, we actually saw significantly more oxytocin immunoreactive cells in the PVH, the paraventricular nucleus, but not in the supraoptic nucleus. And so then we started to think about, okay, well, that's great presynaptically, but what do we think is happening postsynaptically? So we repeated the experiment with a new cohort of animals, and then this time we used oxytocin receptor autoradiography to look for changes in oxytocin receptor density in a bunch of different estrogen-sensitive efferent targets of the PVH, so medial amygdala, BNST, nucleus accumbens, dorsal raphe, a bunch of different areas of the cortex. And we only found a change in one place, and that's the dorsal raphe. So you can see that our estrogen withdrawn animals had significantly more oxytocin receptor density during this sort of simulated postpartum period compared to our no hormone or our sustained animals. And this was a collaboration with Elliot Alber's lab at Georgia State University. So then we thought, okay, well, what would happen if we actually block those oxytocin receptors in the dorsal raphe? So prior to initiating a hormone simulated pregnancy, we implanted our animals with cannulas that were targeting the dorsal raphe, put them through the hormone simulated pregnancy, and then prior to doing our behavior testing, we injected them with either an oxytocin receptor antagonist or a vehicle. And we just looked at elevated plus and open field here because we didn't see a difference in sucrose preference previously. And so what we found is that unlike animals who received vehicle, where again, our estrogen withdrawn animals show this high anxiety behavioral phenotype, that phenotype seems to be reversed in animals who receive this oxytocin receptor antagonist specifically into the DRN. And this is true in the elevated plus as well as in the open field. And so kind of putting it all together, we think that one way that this could be working is that postpartum estrogen withdrawal could be increasing oxytocin transmission between the paraventricular nucleus and the dorsal raphe in order to increase anxiety-like behavior during the postpartum period. Still a lot of open questions, so we don't know what's happening in the DRN. Is this through direct contact on maybe dopaminergic neurons in the DRN, or maybe it's via volume transmission to serotonin neurons. So these are questions that my lab is exploring. Okay, so then I'm going to move into the second story, which is looking at how estrogen withdrawal impacts anxiety and maybe motivation through delta phos-B in mice. So at the same time as we started the oxytocin story that I just told you, we also sort of started this parallel line of research, also in hamsters, looking at whether there was a role for the mesolimbic system in the response to these shifts in peripartum hormones that might be involved in mood or affect. And the reason that we were interested in targeting the mesolimbic system is because we know that it's estrogen sensitive. We know that it's part of this sort of network of brain regions that are involved in maternal behavior. We also know that it's highly plastic, and in particular, it seems to be plastic in response to chronic and intense stimulation. So there's been a lot of really wonderful work done in the drug addiction literature showing that the nucleus accumbens in particular is very, very plastic in response to sort of high frequency or chronic stimulation. And in particular, there's a transcription factor called delta phos-B that's been popularized by Eric Nestler and his laboratory that seems to be a mediator of long-term plasticity within the nucleus accumbens following sort of chronic stimulation with drugs of abuse. But we know that the brain didn't evolve so that people could take drugs, right? And so we thought that perhaps that it would be a good candidate to look at following chronic stimulation with estrogen. And so that's exactly what we did. So we were excited to find that in animals who were estrogen withdrawn, we actually saw an increase in delta phos-B levels. So this is just Western blots showing an increase in delta phos-B in hamsters. So we were super excited, and I was fortunate that my lab as a postdoc collaborated with Eric Nessler's lab in particular to use some viral vectors that you can use to either overexpress or decrease the expression of delta phos-B. So I reached out to Dr. Nessler and I said, oh, we have this really exciting finding. We see delta phos-B go up in the nucleus accumbens of estrogen withdrawn females. So could we get some of that virus? And he said, like, yes, absolutely. But do you know if it's going up in either D1 dopamine 1 receptor or D2 dopamine 2 receptor bearing neurons? And I said, no, I have no idea. And he said, well, that's actually an important question, because at the time his group, as well as Elizabeth Heller's group, had just published a study showing that delta phos-B was actually doing different things in D1 versus D2 neurons in the nucleus accumbens. So he said, maybe you should find that out first. And I said, okay, that's a great idea, but it's actually quite hard to look for D1 versus D2 receptor bearing neurons in hamsters because the antibodies for them are not very good. And so Eric Nessler said, okay, well, have you considered maybe switching to mice? Because then you could use some fancy transgenic reporter mice. So he was able to send us some transgenic reporters that have fluorescent proteins that either glow red for dopamine 1 receptor neurons or green for dopamine 2 receptor bearing neurons. And so we kind of moved this whole thing into a mouse line in order to try to answer this question. And so the first thing that we did is we wanted to go back and just in regular C57 mice, try to actually see whether A, the behavioral phenomenon is there, and B, whether the neural phenomenon is there, whether we actually see this increase in delta phos-B in the nucleus accumbens of estrogen withdrawn females. So that's what we did. So we took our regular C57 mice, we put them through the hormone simulated pregnancy, again, adapted to a mouse gestational timeline and mouse hormone levels. And so this had been done previously, not in C57s, but in a different mouse strain, Ling Chen's laboratory at Nanjing University in China has done some work in ICR mice showing hormone simulated pregnancy in them. And then we did behavior testing. So again, open field, elevated plus, sucrose preference, perfused them, and then looked in some animals for immunohistochemical localization of phos-B, and in a subset of animals using Western blots as well. And we found that thankfully, we in these mice still see the same increase in delta phos-B. So we used both Western blots as well as immunohistochemistry and found that delta phos-B is going up. Interestingly, the change in delta phos-B seems to be driven by the nucleus accumbens core. And I say that's interesting because I think that historically more people have focused on the nucleus accumbens shell with regard to maternal behavior. And so we're interested to see what role the core is playing here. So now that we established that we have the same neural phenomenon, we wanted to see whether we also had the behavioral phenomenon, and thankfully we did. So unlike the hamsters, we actually see that our estrogen withdrawn animals show a deficit in sucrose preference, as well as a high anxiety phenotype in the elevated plus. The open field data is a little bit iffier, so there's some interesting species differences there between the hamsters and the mice. So once we had sort of the behavioral and the brain data established, we decided, okay, now we feel like we can take it into these transgenic reporter mice. And so we repeated again the whole experiment to try to understand whether it was going up, whether delta phos-B was going up, specifically in D1 or D2 receptor bearing neurons in the nucleus accumbens. And so you can see here's what our immunos look like, where we have D1 neurons with phos-B and the double label, and D2 neurons with phos-B and the double label. And we found that it's actually going up in both, and it's going up in both pretty equivalently. And again, this difference seems to be driven again by the nucleus accumbens core and not as much the shell. So then once we had that data, we could finally do the experiment that I wanted to do 2 years prior, right? Which is the viral injections in order to try to prevent the transcriptional effects of delta phos-B in the nucleus accumbens and see if we could shift anything about behavior. And so that's what we did. So this time we're back in just regular C57 mice, and we did a viral injection targeting the nucleus accumbens core, either for delta Jun-D, which is a dominant negative inhibitor of delta phos-B, so it prevents the transcriptional effects downstream of delta phos-B, or just a GFP control. Then put the animals through the pregnancy, tested them for open field and elevated plus. We haven't yet done the sucrose preference. That's actually in progress right now. And then we're looking just for delta phos-B levels as well as our viral injection. And so what we found is that we get really great viral expression targeting the nucleus accumbens core. And we see that unlike our withdrawn animals who receive the GFP control injection, where they have this high anxiety behavioral phenotype in the elevated plus, that's not the case in the animals who receive the June D virus. So that's the virus that prevents the transcriptional effects of FOSB. So again, it seems to prevent that high anxiety behavioral phenotype. And likewise with the open field as well, which is interesting because we didn't really see the open field effect as much in our control animals, but something about the preventing the accumulation of FOSB seems to actually switch them to this lower anxiety behavioral phenotype. So what do we think is happening here? So we think that perhaps decreased binding at estrogen receptors in the ventral tegmental area is causing a decrease in dopamine release from the VTA into the nucleus accumbens that then is increasing delta FOSB levels in order to regulate these behavioral changes during the postpartum period. Still lots of work to be done here. So one particular area that we're interested in is trying to understand what the dynamics are of dopamine release into the nucleus accumbens. So we have a new collaboration with Rodrigo Españo's laboratory at Drexel College of Medicine, where we've actually started doing slice voltammetry to try to look at some of those dopamine dynamics as well. Okay, so then I think I only have about a minute left, so I'm just going to spend the last minute quickly buzzing through some new data. And so that is looking at sleep. And so we know that the peripartum period is a time of profound sleep disruption. And I know that, you know, every parent in the audience, I say that and they're like, yeah, you think, right? And I get it. I have 2 young kids. I don't think I've gotten a good night's sleep in 7 years, so I totally get it. However, there's some reason to believe that it isn't just sort of environmental factors, right? So it's not just that you're getting up to pee every 10 seconds when you're pregnant, or you have a big pregnant belly so you can't get comfortable, or once you have a baby, that the baby is up every 5 minutes, right? Maybe perhaps these hormone changes are actually changing something fundamental about the brain that impacts sleep in ways that actually could be adaptive, right? So perhaps if you actually have a new baby with new caregiving responsibilities, perhaps you would want your sleep to be lighter or more fragmented so that you could awake more easily and take care of the baby. And so we think actually the hormone simulated pregnancy model is a really nice model because it allows us to tease apart some of those environmental effects from the hormone effects. And so that's exactly what we've been doing. We've been using this model again in hamsters, and then actually just recording actigraphy data. So we just take 24-hour recordings in the animal's home cage, and then we're using Novus Ether Vision to take actigraphy data at 7 different points during the pregnancy, 2 pre-tests before we start the hormone injections, 2 during early pregnancy, 2 during late pregnancy, and then 1 during the postpartum period. And then we've started actually looking for changes again in the dorsal raphe nucleus, but this time focusing on the serotonin system, looking at its role in sleep. And so I will skip the video and just tell you that we've been able to collect good actigraphy data, and we're seeing changes that seem to be specific to the white light period. So this is, what would be the hamster's daytime, where we would be expecting them to sleep more. And we see that in animals that are treated with hormones, they're actually sleeping less during late pregnancy and during the postpartum period. However, this continues for animals who are those estrogen sustained animals, but in animals who are estrogen withdrawn, those levels start to drop off. And that's true as well for sleep efficiency, as well as how much they're actually moving around. And this actually seems to be our most profound effect here, that during early pregnancy, late pregnancy, and in the postpartum period, our hormone treated females are actually moving farther than our oil treated females during the daytime, and then our estrogen withdrawn animals are showing this sort of intermediate phenotype. And so we think this is really interesting. We've started to look at these serotonin changes. We find that if we look at FOSB as, again, a marker of plasticity in the dorsal raphe, we see an increase in our estrogen sustained animals, but not in our estrogen withdrawn animals. And if we look at the number of double labeled cells between serotonin neurons and FOSB neurons, we also see that increase that seems to be specific to the sustained animals. This is a relatively low number of double labeled cells. So even though the pattern is there, we're still really unclear about what sort of this means biologically. And so that's it. I hope that I have been able to convince you today that peripartum hormone fluctuations do in fact lead to these profound changes in the brain and behavior. And I hope I've also convinced you that you can actually do meaningful work with just undergrads. And if that's something that anybody wants to ask me more about, particularly if there are any trainees in the audience, I'm happy to field those questions. But then with that, I thank you for your attention, and I'm happy to take any questions.
Thank you so much, Dr. Bean. Well,
Sure.
I'll do the audible clap. And we do have maybe time for one really quick question. Karen has one and I have one too. Karen, did you want to unmute yourself and ask your question?
Sure, yeah. My question is pretty simple. I'm just wondering, in animals, things happen generally, I mean, often for a reason. I'm just wondering if the increased anxiety in mice, hamsters, could be adaptive in some way, making them more vigilant for retrieving pups that wander from the nest, say, whereas in humans, the constellation of mood changes can be debilitating in some way. But I was just wondering if you thought about the potential purpose, if anything.
Yeah, thanks for that so much. Yeah, we have. I think that with both the anxiety behavior and the sleep behavior, we've been trying to think about it in terms of possibly an adaptive change, right?
Yeah.
Especially I think for first-time parents, right? You
Mhm.
suddenly have these offspring that I mean, this is relatable, I think, to every first-time parent. It's like, oh gosh,
yeah.
now you have to do something with this baby, right? And so I think having increased vigilance or, perhaps lighter sleep, for example, to be able to respond, and this is true, I think, for a wide variety of organisms, ranging from mice to humans and probably lots of other things in between.
Yep.
I think you're right, though, is where it sort of veers into the pattern of maladaptive is when it sort of persists beyond where it's appropriate, right?
For sure. Yeah.
And that's a lot of what they see in the sleep literature is that many women report experiencing sleep dysfunction that lasts sort of beyond the initial postpartum period. And so we're interested in trying to see how far we can take this out and to try to understand when it sort of switches from adaptive to not.
Yeah. Thank you. Beautiful.
Sure.
That was going to be one of my questions is, how long do you see some of these effects? But unfortunately, we have to keep going on with our time. But if we have time at the end, for sure, we'll come back. Thank you so much, Dr. Bean. Now, I'm really pleased to introduce Dr. Robert Paul Juster. Robert Paul's research focuses on teasing apart the role of biological sex and social cultural gender and explaining pathways that render us vulnerable or resistant to stress-related disease. And he's become an expert in the measurement of allostatic load. Yes, he has. The wear and tear of chronic stress and unhealthy behaviors. He is the director of the Centre d'études sur le sexe, genre, l'elasticité, et la resilience. It's the acronym is CSER, which is great, at the Center for Research at the University of Montreal, I'll say. And he's also an assistant research professor in the Department of Psychiatry and Addiction at the University of Montreal. See that my French, I can't speak as rapidly in French unless I say something like avec le pamplemousse dans la salle de bain, which doesn't mean anything. So his fun fact is that he once dreamt of becoming an actor since he loves impersonating people. Robert Paul, that's me too. I loved this. I wanted to become a actor too. Anyway, without further ado, take it away.
Along so well. Thank you so much, Lisa, for the invitation. Can everyone see my slides? All right, so I'm just going to start off with some acknowledgements for the many people and the funding that were involved in this research. In particular, the late Bruce McEwen, who was really the person who spearheaded the allostatic load model. And so today's presentation is going to focus on how to incorporate intersectionality into allostatic load research. Now, I just want to start off by saying that I'm really a student of intersectionality. I don't pretend to be an expert. I really will point you out to this Meet the Method series by Greta Bauer, who's really much more of an expert than I am. My definition of intersectionality is that it refers to combinations of overlapping and conflicting dynamics of race, ethnicity, gender, class, sexuality, nation, and other inequalities. And so the idea is that it's not this additive Black plus lesbian plus woman, but it's really Black times lesbian times woman. And it's this compounding of marginalization. Right off the bat, a lot of people argue that intersectionality can only really be studied qualitatively. I'm going to try to propose some work that looks at it more quantitatively. And in today's presentation, I'm going to focus on gender roles, sexual orientation, and gender identity in relation to allostatic load. So I'm going to jump right into the allostatic load model. So the allostatic load model really argues that environmental stressors, major life events, trauma are all going to shape the way the brain processes information and stress thereon. And that in turn will also be influenced by individual differences, behavioral responses, and physiological responses that will lead to adaptation. But when these systems are activated chronically, such as in marginalized situations, this creates wear and tear on the brain and body. And so allostatic load is defined as the wear and tear of chronic stress in synergy with unhealthy behaviors that exact on the brain and body. And the idea here is it's the straw that breaks the camel's back. And it involves more than just cortisol, or involves more than just cardiovascular functioning. It's really this multi-systemic network of biomarkers that become dysregulated over time. One way to think of it in terms of a good analogy for the general public is two little kids on a seesaw. You know, the seesaw won't wear out as much because these kids are light. But if you imagine sumo wrestlers bouting it out over time, the seesaw will wear out. The important point is that allostatic load is more than cortisol, as I mentioned, and it's also more than just clinical ranges. Allostatic load is a combination of dysregulated biomarkers in an array that involves subclinical as well as clinical cutoffs. So this is just a graphic to show basically the model and the temporality of the model. So primary mediators involve stress hormones, inflammation. This leads to cellular changes over time that leads to secondary and tertiary outcomes, which is really the traditional biomarkers that are used in medicine to predict disease. One way to think about allostatic load as well is as a kind of domino effect, where you have these key kingpin biomarkers like cortisol and cytokines that get dysregulated over time. That leads to changes in a lot of traditional biomarkers in biomedicine. And together, this will lead to increased risk of morbidity and mortality. And so allostatic load was first calculated in the context of successful aging. So here you see these 10 different biomarkers that are all in some way related to stress. And they use the 75th percentile for biomarkers where high levels were problematic, and the 25th percentile for biomarkers where low levels were problematic, such as HDL cholesterol, which is good cholesterol. And what they found using this allostatic load index was that it was better than using individual biomarkers, which makes sense. It was better than using the metabolic syndrome or Framingham cutoffs in cardiovascular functioning in predicting cardiovascular disease, in predicting cognitive decline, physical decline, and all-cause mortality. Another way to calculate allostatic load is based on clinical norms. So here you see an individual has 7 because cholesterol passes 5.2. But this individual actually develops diabetes in 2 years. And if you look at their glucose, it's quite high, not quite at 6, but 5.4 is pretty high. Same thing for triglycerides. And then their HDL cholesterol is high, but that's fine. So for these 4 biomarkers, this individual would get a score of 3. And now in the allostatic load literature, we see over 200 studies that have used this formulation. And here what you see on the x-axis is the number of studies. This was 10 years ago, so it's changed quite a bit. But you see real representation of a lot of different biomarkers used in stress research. And what came from a lot of the epidemiological work was that increased age, non-white race ethnicity, low social economic status were consistently related to allostatic load, and really intersections among these were extremely problematic. So for instance, being a Black woman in poverty was increased to an exponentially higher allostatic load that was related to more disease outcomes over time. Sex as a variable, however, is really quite inconsistent. And the only studies that have actually looked at sex differences beyond just looking at it as a covariate have found that in general, men seem to have higher allostatic load than women. However, when we actually look at the factors that can contribute to allostatic load, a lot of them are really related to gender, more so than biological sex. So being a woman and attending religious services regularly was related to lower allostatic load, not a finding among men. Older men benefit from being with their wives much more than wives benefit from their husbands. Wives benefit more from same-sex social networks. And then workplace stress, hostility, all kinds of these different variables were related, in my opinion, more to sociocultural gender than sex per se. So that got me thinking about how it'd be really interesting to think about the allostatic load model beyond just looking at sex as a binary. So some of my work has looked at sex hormones, but also sociocultural gender. So gender roles, sexual orientation, which isn't quite gender, but there's a lot more gender diversity in the LGBTQ community, and gender identity. So starting off with gender roles, I did a small study during my master's where we looked at gender roles in allostatic load. And much of the research had shown that women in non-traditional occupational roles experience greater distress and espouse greater masculine gender roles than, and what I mean by non-traditional occupations, these are managers, engineers, and this was in the 1980s. And what was found in this work was that these women had higher indices of stress pathophysiology. So I wanted to see whether gender roles, so masculinity and femininity, would be related to allostatic load. And what we found was that a more masculine type individual in terms of personality traits had higher allostatic load. Women that had that had more masculinity had more physical symptoms, and more physical symptoms was related to higher allostatic load. This was a really small sample of 30 participants, but it really allowed us to identify that sex and gender roles were important for allostatic load. And so later on in a study of 204 workers, we wanted to test a very popular theory in psychology. And it's the idea that having both high masculinity and high femininity leads to an androgynous profile. So it's not about the way that you look, it's really your endorsement of these masculine stereotypes and these feminine stereotypes. So masculine traits would be being independent, assertive. Feminine traits would be being understanding, being sympathetic. And so individuals that are high on both of these traits are considered to be more adaptive, while those that are scoring below the average would be considered undifferentiated and would show poor mental health. And so this is exactly what we found. Independent of sex, individuals that were more androgynous had higher self-esteem, higher well-being, and less depressive symptoms. Now, in terms of allostatic load, we had an array of 20 different biomarkers. And we calculated allostatic load the way it's normally done, which is what I call all-inclusive. So it creates cutoffs based on the group's distribution without any consideration of sex. And that's really problematic because for these 20 different biomarkers, there were at least 10 of them that were different for men and women. So we also used a sex-specific formulation in order to nuance things a little bit more. And so when we use the all-inclusive approach, we see that men have higher allostatic load than women. But then when we use the sex-specific approach, we unmask a sex by gender role interaction where androgynous men are showing the lowest allostatic load, while undifferentiated men are showing the highest allostatic load compared to undifferentiated women. So a lot going on among the men, but no differences were found among women. I mean, that's something that we're exploring more in my lab right now by going beyond individual gender roles and trying to understand occupational gender roles. So what is the attributed masculinity and femininity of your profession? What is the sex composition of men and women and gender diverse people in your occupation? And then moving even more macro than that, trying to understand gender relations, gender norms, and institutionalized gender. And some of the work of Louise Pilat has applied this thinking in ways of using socio-demographic variables in order to better understand gender. Moving now to sexual orientation, we know that LGBT individuals experience more stress-related diseases due to stigma, and this stigma comes from two important processes. So distal stress processes, which refers to more macro-level discrimination, victimization, violence, and more proximal stress processes. So internalized transphobia, the coming out process. So I'll give you some examples in relation to cortisol. So here you see stress reactivity of individuals in the United States that grew up in states that had more or less structural stigma. And structural stigma can be indexed by looking at the laws in place at a particular time that protect LGBT individuals. And so those that grew up in more high structural stigma areas had a more blunted cortisol response. And this is something that's seen in the discrimination literature. Now moving to more proximal stress processes, here is a really classic study by Stephen Cole that shows that individuals that are HIV positive, that disclose their status to family and friends, show greater survival over time, lower declines in CD4 decline, and ultimately live longer than those that are still kind of in the closet with regards to their status. And then there was a really interesting study from Arizona showing that men that had come out of the closet at work actually showed higher levels of cortisol and more negative affect. And this is an important factor because some of the work I'm going to show you now shows you the opposite, but it really points to the importance of geography It points to the importance of developmental milestones like the coming out process. And so here's one of the first studies looking at stress reactivity as a function of sexual orientation. You see that lesbian and bisexual women actually have higher levels of cortisol 40 minutes after being exposed to the TRIAR social stress test. Now, when we compare it to men, gay and bisexual men show a blunted response compared to heterosexual men. If we were to just look at this pattern, we would say, well, maybe they're not stressed out, or maybe this is some sort of pathophysiological profile that we see in discrimination and trauma. But because we took a multi-systemic approach, we actually found that gay and bisexual men actually showed higher levels of heart rate throughout the stressor. Yet they were also showing lower levels of cortisol. So this really points to the importance of taking a multi-systemic approach that is really in the spirit of the allostatic load model. Now, in terms of diurnal cortisol, so the day-to-day rhythm of cortisol production, there were no differences as a function of sexual orientation, but we found that those individuals, so just looking at lesbian, gay, and bisexual individuals, those who had completely come out of the closet had lower levels of cortisol than those that had not completely come out to family and friends. In terms of mental health, we didn't find any differences except that gay and bisexual men showed less depression than heterosexual men. This was a finding not consistent with sexual minority stress theory, but it was being driven largely by more gay and bisexual men that were out of the closet. And those that were out of the closet had less anxiety, less depression, less burnout. Now for allostatic load, 20 biomarkers in total. We found again that gay and bisexual men had lower allostatic load than heterosexual men. And this was driven by lower body mass index, lower triglycerides, and lower cytokines. And it wasn't related to coming out of the closet. However, we did secondary data analysis and found that those individuals who engaged in less avoidance coping showed lower levels of allostatic load. So obviously this is a Canadian study, there's selection biases. Stephen Colbert even laughed about this study, saying that it was done with Canadians, and so it would have to be replicated with real humans. So that was what inspired me for my postdoctoral work to go to the US and see, would we see the same thing in a larger sample in the US? And so I had access to a database with about 14,000 Americans, and we found exactly the same thing. Gay men showed lower allostatic load compared to heterosexual men. But now, because we had enough of the subsample groups, we found that bisexual men had higher allostatic load than all other groups. No differences were found among women as a function of sexual orientation. And this was interesting because lesbian women actually had higher body mass index. However, they had a more healthy lipid profile than heterosexual women. So what could be explaining this? I think it has a lot to do with health behaviors that we're going to be looking at more in the future. Now for one example of an intersectional study. So this is work done with Stephanie Cook that looked at men who have sex with men who are white or black. And what we found was that those men that were black actually had a flattened diurnal rhythm of cortisol. And this was really one of the first studies that tried to chip a little bit at the concept of intersectionality. But really, in order to do intersectionality research, as I think it should be done, you'd need to have a heterosexual contrast group, you'd need to have women. So it becomes quite hard to do these kinds of studies with sufficient sample sizes. Now for the final part of my presentation, because I'm running out of time, is gender identity. And this is a study done with Zachary Dubois at the University of Oregon that looked at transitioning transgender men in the state of Oregon, Vermont, and Massachusetts, and found that those that had reported more stress with regards to transitioning, coming out, and public restrooms had higher levels of cortisol throughout the day. Now, Zachary did beautiful qualitative interviews to try and understand different factors that contributed to this, and also measured a nice array of biomarkers that we're currently working towards measuring allostatic load. And what we're doing is we're indexing a lot of information from qualitative interviews to try to get a sense of different factors in someone's life. So geopolitical progressiveness, so where people live geopolitically in these states, socio-demographic advantage, social support, trans-specific stress, and unhealthy behaviors. And we're looking at these different indices in relation to distress, mental health, and allostatic load. And what we find is that for perceived distress, it's geopolitical progressiveness and trans-specific stress that seems to be the most important factors. Same thing as well for mental health. But for allostatic load, if you live in a less progressive geopolitical space, and you have more socioeconomic disadvantage, you have higher allostatic load. And so this, in conclusion, this work is really important in bringing together different types of identities, different forms of stressors that are all related to biomarkers. And what's unique about this work is we're really integrating stress biology to a lot of work that's been done in public health, in psychology. And moving forward, it's going to be really important to understand more resilience of coping strategies, social supports, and community resources, and really trying to take an intersectional approach by being transdisciplinary in spirit of bringing together these different disciplines. And in closing, I'm just going to show a graphic that I know Lisa enjoys, and it shows the different factors that have been in some way related to allostatic load, and it shows what allostatic load is predictive of. And in today's presentation, I tapped a little bit at sex, a little bit about sexuality. Gender isn't even in this model, but you can imagine that all of these different factors interact together, not necessarily in an intersectional spirit, but there's a lot of interactions among these variables that will need to be nuanced further in the future. And with that, I'm just going to do a shout out for an ongoing study of mine that's looking at sex and gender in relation to COVID, and I'll put the link in the chat box. So thank you.
Wow, fantastic, Dr. Juster. You always make my brain expand whenever I hear you talk, because I think I understand intersectionality, you know, being mostly biological, binary male, female, rat modeler. And then I listen to your talk and I think we can do so much better. And you really, you raise the bar. Every time I hear you talk, you raise the bar. So thank you very much for, I mean, I was just, you know, and I'm sure many of us were sort of blown away by just all the different things. And it shouldn't be so surprising that can affect allostatic flow, right? Geopolitical, what did you call it? Geopolitical
Progress.
I mean, that makes so much sense. And then, of course, whether or not, you know, I guess, you know, disclosure could also, you could also think about that in terms of social support implications too, you know, whether or not you're out, that also might be a factor there. So how do you, and I know you showed that one, and somebody else, I'm sure will have a much better question than me, but you know, you showed that diagram with all the, like, I think you were talking about looking at race and ethnicity along you know, all these different balloons. Like, how do you sort of, what would be your best advice for people moving forward in terms of thinking about intersectionality in their own research?
I think it's really by taking mixed design approaches. So right now I've presented how I've been thinking about it from a quantitative perspective, but I really would encourage people to consider it qualitatively when working with humans, because I think that's truer to the spirit of intersectionality the way it was originally defined. I do think, that being said, finding ways of combining information, even if it's not multiplicative or interactional, I think is really important. And one way that I've tried to tap at this with some other work is there's really good discrimination questionnaires that look at multiple different identities that are marginalized. And what I've tried to do is combine these to see, you know, individuals that are experiencing multiple forms of marginalization. And what I found is among older gay and lesbian New Yorkers, those that reported more stigmatized identities had higher levels of cortisol throughout the day. That makes a lot of sense. It's not really very surprising, but being able to really show that combination of discrimination, identity, and objective biomarkers is really quite powerful.
Yeah, I mean, I don't want to, I don't think animal researchers should be off the hook. So, you know, there's been a little bit of discussion about this, and I don't want to make sure we have enough time for Nafisa, so I'm going to make this really short, but you know, in terms of age, environment in the cage, you know, there's the genetics of, I mean, Dr. Beaton talked about Syrian hamsters versus mice, and then there are different strains of rice and all of these. And it might sound trite, but all of these things make a big difference, even their lab chow, right? Because it's going to affect their triglyceride levels and things like that. But one of the pushbacks I've gotten in my own grants has been, it's like, you know, you get that fishing expedition, like you're looking at too many, it's too complicated and yeah, sure, but the thing is, we haven't gotten super far when we're not complicated. right? So I don't know how you do you get that same, do you have any advice for that? You're fishing, there's too
Yeah,
many
I've
things you look at.
sometimes done reviews back where they're like, you can't measure intersectionality quantitatively. Like I actually received that as a review, and obviously it's it hurts to hear that, but I think that I have to humbly sort of accept that and learn more. And actually, I just want to shout out. I just found out that there's someone at the University of Montreal I don't even know, called Surma Bilge, who just wrote a book on intersectionality. I think and she's in the School of Sociology. I think it's really going to be by doing transdisciplinary work and
Yes.
combining these different disciplines that we'll be able to think outside the box.
Yeah. I love it. I love it. And I think we need some more discussion about how we can do this. So thank you so much, Dr.
Thank
Juster.
you.
Really appreciate it. Dr. Ishmael, shouldn't call you Nafisa, but that's who you are to me. I'm really pleased to introduce Dr. Nafisa Ishmael. She is an associate professor at the School of Psychology at the University of Ottawa and the holder of the University Research Chair on Stress and Mental Health. She obtained her PhD from the Concordia University in 2009, and she then completed a postdoctoral fellowship at the University of Massachusetts and joined the University of Ottawa back to the University of Ottawa in 2012. Her research expertise is in neuroimmunology and neuroendocrinology. She was recently awarded the Young Researcher of the Year by the University of Ottawa and Early Researcher Award by the Province of Ontario. She's a member of the Global Young Academy. I don't even know what that is, but clearly I'm not young, so that's probably why I don't know about it. And her fun fact is that she's always wanted to learn to play piano as a child, but she never got the opportunity. But now during the pandemic, she started taking online piano lessons and she's loving it. Great. Good job to you. Thank you, Dr. Ishmael.
Thank you so much, Dr. Galia, for this generous introduction. And thank you all for attending. I'm really so honored to be here. So I'd like to thank Lisa and Kathleen for putting this together. And I'm really excited to talk to you about this new data that we've had in the lab examining the impact of oral contraceptives on the brain. So combined oral contraceptives are those contraceptives that contain both some concentration of synthetic estradiol and some concentration of synthetic progesterone. And they are the most widely used method of reversible contraception. Women have been using them for many, many years, actually since the 1970s. And today we see that more than 100 million women around the world use them. But what we see is that of these women, about 56% report secondary side effects from them, such as trouble regulating emotions, irritability, depression, intensification of premenstrual symptoms. And about 30% of these women have to actually discontinue using oral contraceptives just because of all the psychological side effects associated with the issues regulating emotion and irritability and also depression. But when we look in the literature, you will see that there is this lack of consensus. There's like these opposing findings when it comes to whether the more contemporary forms of oral contraceptives that we have now that have less of a concentration of synthetic hormones and the role that these may have in predisposing women to depression. And part of this issue is really bigger picture that there is a significant lack of research with regards to women's health. And you know that already with these series of symposium. But when it comes to depression, even though it is so widespread and we see that more than 264 individuals globally are affected by depression, there is still a lot of unknown related to it. In a recent report by the World Health Organization, it was not that recent, but it was published in 2017, they predicted that depression would become the leading cause of disease burden in 2030. But now we can imagine that with the current pandemic and the isolation and so on, that this may come much earlier, actually. So we know a little bit about the pathophysiology that underlies depression, such that we know that it's associated with dysfunction in monoamine neurotransmission, that has been studied widely in the literature. The current pharmacological treatments we have target these systems and try to normalize them. But then we also know that in many cases, these pharmacological treatments are not effective, suggesting that there is more to depression than simply a dysfunction in monoamine neurotransmission. For instance, we also know that certain stressful life experiences can induce depression and anxiety. And here I'm referring to stressful life experiences that are going to not only activate our stress system, but also our immune system, and are going to cause this low-grade chronic inflammation that can then predispose an individual to psychological illnesses. What's interesting is that most cases of depression and anxiety start during puberty and adolescence. Actually, the mean age of onset is 14 years of age, which corresponds to about the time that girls are going to begin using oral contraceptives when they started during puberty and adolescence. We also see that women are more susceptible to developing depression after puberty. So could there be a link here? Could there be a link between the use of oral contraceptives during puberty and the increased susceptibility to depression? So puberty, as we know, is a critical period of development for sexual maturation. It is during this period that our HPG axis becomes active. With that comes all the production of gonadal steroid hormones that will then lead to the development of secondary sexual characteristics and also the remodeling and reorganizing of our brain. But when oral contraceptives are used during this time, the synthetic hormones that are contained in these oral contraceptives sort of hijack the system, and they're going to come and bind to the same receptors as the endogenous hormones, and we're going to leave pubertal and adolescent development in the hands of these synthetic hormones. So it's important to know what the impact of these hormones are on the brain and on mood disorders as well. So in our first study, we wanted to examine whether OC usage during puberty affects brain structure. So in this study, we had participants that were on oral contraceptives that either began during puberty, and we had 12 participants there, or that began during adulthood, and we had 15 participants in that group. Then we compared them to naturally cycling women that we captured at different stages of the menstrual cycle, namely the follicular stage, pre-ovulatory, and the luteal phase. And so the women that began taking oral contraceptives during puberty began sometime within the first 6 months of starting menarche, and they didn't discontinue the usage. We didn't mind it if they changed the contraception, but they did continue using it throughout their adolescence and now in adulthood as well. Those that began using oral contraceptives only during adulthood began at 18 years of age, and they had been taking these oral contraceptives for a minimum of 3 months when we tested them. For the naturally cycling women, they had never taken oral contraceptives, and we captured them either during the early follicular phase, which was day 2 to 6 of their menstrual cycle, or during the pre-ovulatory phase, days 10 to 14, or the luteal phase, which corresponds to days 18 to 24 of the menstrual cycle. So when we compared all the oral contraceptives users to all the naturally cycling women and examined gray matter volume, which represents mainly cell bodies of the neurons, glial cells, and what we found is that OC users show a decrease in gray matter volume in the right putamen and as well in the left postcentral gyrus compared to naturally cycling women. The right putamen is this area involved in motor coordination, whereas the left postcentral gyrus is involved in integrating somatosensory information and memory formation. Then we compared white matter volume, which now corresponds more to myelinated axons. What we found is that OC users showed increased white matter volume in the right putamen, so the area where we had seen actually a decrease in gray matter volume, and also an increase in white matter volume in the left parahippocampal gyrus compared to naturally cycling women. And when we specifically compared those that began using oral contraceptives during puberty, there was increased white matter volume in the right fusiform gyrus, this area that plays an important role in language recognition. So it was interesting to see that there were some effects that were quite general to OC users, but then there were also some particular structural differences that were limited to pubertal onset oral contraceptives users. So just to summarize this aspect, we see that oral contraceptive users display increased regional gray matter volume, but then also an increased regional white matter volume. And we're wondering whether there might be this possible compensatory mechanism where when there is a decrease in gray matter volume, the brain tries to compensate by increasing white matter volume. We also then wanted to see whether these oral contraceptives that are being used during puberty, are they having these long-term changes in brain structure? Remember that our participants didn't discontinue using oral contraceptives, so they really used them throughout. But one question that lingered in our mind is if they did stop using them, would these differences still remain in adulthood? So that's something that we want to investigate further. But here, we then moved on to examining whether any of these structural changes are related then to functional changes in the brain, and maybe even mood-related changes in the brain. So here we exposed our participants to a customized NBAC task in which they were exposed to a series of pictures ranging from neutral, negative to positive images. And we asked the participants in some of the tasks to remember 2 images that they had seen previously. So we call it the 2-back task. And when we did that, we saw that oral contraceptives users showed more bold response in the right inferior frontal gyrus, which is this area that plays an important role in cognitive function. We'll see it being involved in attention, in motor inhibition, and so on. When we were asking them to remember 2-back negative images, so negative images that they had seen 2 pictures previously, compared to naturally cycling women. So it's as though these negative stimuli were activating the brains of OC users more than the naturally cycling women. Whether this means that the brain has to work harder to remember these images, or these images are just eliciting more activity in the brain, that still remains to be examined. But that was one of our observations. And when we looked more specifically at pubertal onset OC users, we saw that they displayed greater bold response in the right insula as well as the right precentral gyrus during the 2-back versus 1-back task for neutral images. So here this led us to think that it had to do perhaps with greater activation during cognitive tasks, where in individuals that began using oral contraceptives during puberty, when they need to work harder on a cognitive task, there is more activation in these 2 brain regions compared to women that began using oral contraceptives in adulthood. We then examined resting state functional connectivity, because what we have been seeing in the literature is that there is this rhythmic and synchronized fluctuation in brain activities between various groups of regions that we call network, and changes in the rhythmicity of these networks has been associated with psychological illnesses. So we wondered whether resting state functional connectivity is affected by oral contraceptive usage, particularly in some of the networks that we were interested in, such as the limbic and the executive networks. So we also wondered about this putamen, which is this area where we had seen sort of this compensatory mechanism happening between the reduced gray matter and increased white matter. And we wonder whether there was any change in resting state functional connectivity in this area. So what we found is that oral contraceptive users showed increased resting state functional connectivity in the salience and the central executive and the reward networks compared to naturally cycling women. They also displayed more resting state functional connectivity in the putamen seed that we had specifically designed, as well as the frontal cortex compared to naturally cycling women. And now looking more specifically at women that began using during puberty, we see that pubertal onset OC users show increased resting functional connectivity in the salience network compared to adult onset OC users. So then we expose our participants to a stress task, the TSST, Trio Social Stress Test, which consists in exposing the animals to a social performance test where they need to give an interview, a mock interview, and then do an arithmetic test. So we collected saliva samples throughout the different tasks, and then we examined cortisol levels in the saliva between oral contraceptive users that began using during puberty or only in adulthood. And when it came to actually the task itself, we found no difference in terms of how reactive they were to this stressful task. But what was interesting was in terms of the recuperation after the task, where as soon as the task was ended, the arithmetic task was the last piece. As soon as that was ended, we see that the pubertal oral contraceptive users come down much, much faster, and then they remain lower too, compared to those who began using oral contraceptives during adulthood. And this still needs to be investigated further. I mean, it could be better adaptability. The stress is over, you recuperate from it faster. It's still a change in stress reactivity and in the HPA axis that's worth investigating further. So to conclude, our work is showing that oral contraceptive usage is related to neurophysiological differences in brain structure and function, and also that perhaps these OC usage during puberty could lead to long-term differences in stress reactivity, changes in terms of brain structure, brain function. And really, the reason why we did this task was not at all to either encourage or discourage the usage of oral contraceptives. It was simply to put the information out there, first to show that there is an important lack of information for women, and that we need more information so that women can make an informed decision as to when they would like to begin using oral contraceptives if they want to go that route. So with that, I'd like to thank my graduate students. This work was mainly led by Rupali Sharma, who graduated recently from the laboratory. Several undergraduate students as well as international visiting students also contributed to this data collection, so I would like to recognize them as well. Our funding agency and you for your time. Thank you.
Sorry, you think that I'd be an old hat at this, trying to unmute myself, but that took me forever. Thank you so much, Dr. Ishmael. That was really fantastic. Yeah, I don't see any questions in the chat, but please put anything in there that you want. I have a couple of things. One is maybe an easy one, and I think I know your answer. And Robert Paul has a question for you too. But did you look at all at why they started taking oral contraceptives during puberty? Because you can imagine that psychologically that could be, if it was for a health reason, could be very different than, sexual experience.
Oh, yes, absolutely. That is a very important question. Actually, most of the women that participated in our study and began using oral contraceptives during puberty did not do it because they were sexually active. It was really for regulatory purposes, either because they had heavy menstruation, lots of premenstrual symptoms that they wanted to taper down. Acne was another big one. So it was really because of all these hormone-dependent consequences, and it was sort of a way to regulate. So it wasn't necessarily because they were sexually active.
Yeah, because that's always been one of my questions about the finding that Dr. Juste is sort of asking about, which is my understanding. I know there's 2 huge studies that came out about oral contraceptives or hormonal contraceptives and whether or not there was an increased risk for depression. And one said yes, and one said no. So that's always fun when that happens in the literature. But my sort of my takeaway from that was age related. It seemed like it was age related. So if you started earlier, you're more likely at increased risk. So did you see? Actually, Dr. Juste is capable of asking his own question.
Well, I think that's it. The way I worded it in the chat box is pretty much. I've just given a lot of thought about developmental milestones like age of menarche, age of menopause, first pregnancy, and then superimposed on that, what age did you take oral contraception? At what age did you maybe take medications as well? And I think from a kind of like more gender perspective, people that have taken oral contraception, I think would be more likely to be adherent to taking antidepressant medication. So right off the bat, I feel like that's already a very interesting set of questions. So anyway, it's just something it's more of a mental fart than anything.
It's a very important point, because the reality is that factors that contribute to vulnerability to depression are numerous, right? And so and it's the reality of who we are. So many life experiences are going to define who we are. There is all the genetic background that may also increase our vulnerability and so on. Personality, ways of coping with stress, exposure to trauma, so on, psychological stress. So of course, all these factors can increase the vulnerability to depression. What we are seeing though, because there is that increase in sex difference in developing depression between boys and girls once they enter puberty. In terms of the animal work that we've done, we see that it's not only dependent on the gonadal steroid hormones. So even though like we remove the gonadal steroid hormones, when they go through puberty, if you expose them to stress, they will still develop depression-like behavior. So we think that it's something that's much beyond that, and that's what led us to, in the mouse world, in our mouse research, to try to examine what these stressors are. And then we came upon this for humans, that perhaps it could be oral contraceptives, because as Lisa also mentioned, the literature is so contradicting. You'll read one paper and they'll say yes, the other paper will say no. But there is also a lot of factors within each studies that are controlled differently. Some will differentiate based on the age of onset of usage, some won't. So yeah, it's hard to bring all this literature together and really see if there is any link between mood disorders and oral contraceptives. Anecdotally, we know that a lot of women report them and they talk about them. They will stop using them because it's just so intense. Because if they want to continue taking them, then they have to add on the antidepressant, and they don't necessarily want to do that.
Yeah, and I know at the risk of getting too personal, though, I also don't know if anybody's done this, but in mid-age with perimenopause, right, when you have these just sort of more dramatic fluctuations, that was I found myself having, sometimes stories are good to have, but having a lot of rage. I remember this very, very vividly because I was in Venice and it was beautiful and I loved it. And I was like, why am I so ragey? This is like I went back to the doctor, said, I want to go back on the pill. Getting too much information, but it really helped. Like that irritability and that rage went right down. So that's also an interesting question. Some people will report they have more depressive-like symptoms. Some people will report they have less. I mean,
yes,
age is probably
no, but it's a really good point, because actually it's true that a lot of menopausal women, as they go through this period and they're undergoing these natural changes in hormone are going to experience these novel symptoms of hormone withdrawal in some sense, but oral contraceptives do help in tapering those down. Yeah, that's it.
Yeah, it's really, it gets, and the other thing I just thought was, Dr. Juster talked about sex specific, the need for sort of thinking about sex specific norms. I also just really heard a really great talk by Michelle Melke talking about the same thing in terms of cognition, like sex specific norms later on in life. And we don't, right? Often in the work, you have one norm. Maybe you'll have it by education, but not by necessarily with sex. But now I'm thinking we probably need it for everything really, geopolitical, whatever it is. I still can't remember what that is, but also for hormonal contraceptives. Okay, I was just about to close out, but there's one more question from Stephanie and then we'll close out. Stephanie, did you want to unmute yourself? No, it's okay. All good.
Sure, thank you. I really enjoyed your talk, Dr. Ismail. I was just wondering if you or any of your colleagues are planning to look at progestin-only contraceptives or even the use of IUDs in adolescents instead of these combined contraceptives. Maybe, I don't know if they're progestin-mediated or estrogen-mediated effects that you're seeing, but is that a future direction?
Yeah, absolutely. Here we did not make that distinction. We just went with oral contraceptives and mixed, estradiol, progesterone. That was the only criteria, just because it was our very first study and we were worried that if we become too restrictive, that it will be difficult to recruit. But we do want to now become a bit more specific. Already now we are seeing, when we were comparing progesterone versus estradiol concentration in the saliva and trying to draw correlation with some of the structural and functional changes that we saw, we did notice that actually progesterone seems to be driving a lot of differences that we noticed. So we published some in the papers, but we definitely want to dig into that much, much more.
That's really interesting and important, especially because all the different progestins have very different, pharmacokinetics and dynamics based on their derivatives. So that's super cool. Thank you.
No, thank you for your great question.
Thanks for doing this work. It's really important.
Thank you very much.
Okay, well, I'm going to, please ask us all to give an emoji or rethank the speakers for their amazing talks. So thank you so much. I know that we're all getting virtual Zoom fatigue, but thank you so much for agreeing to do this. Thank you for excellent talks and it really expanded my brain. And for that, I thank you. Neuroplasticity, right? Like use it or lose it. So you really made me use it this morning, trying to tweet like crazy. So thank you again. And I'm sure they all welcome questions from you. If you have any more, send it to them in an email. And with that, have a great rest of your morning or afternoon, wherever you are in the world.